see my screen?
Yeah, we can see your screen. You just have to go to full screen. Lovely. So I'm just going to give an introduction.
1 second. Are you seeing the full slide or are you seeing presenter view?
We're seeing the full slide.
Full slide. All right. Wait. Yeah.
Actually, we're seeing the presenter view.
Let me just. Still seeing the presenter view.
I had the same problem. You just need to go to display settings and change the monitor.
Have you got a dual monitor?
Up.
Yeah, I've got dual monitor.
You need to choose screen 2.
I'll just take off them.
Yeah, perfect. So I'm just going to give a short introduction for Dr. Jasim Shihab, who's a consultant neonatologist who was previously working in the UK, but is now relocated back to India and is the group head for neonatology and pediatrics in Sabine Group of Hospitals in Kerala. Jasim is a very close friend of mine, but also has been teaching for the Improve Academy, I think, for the last decade, and that he has a wide variety of interests besides neonatology, which includes simulation, human factors, and in particular, designing some really difficult mannequins. So he's also one of the co-directors for the Improve Academy. And today, what he's going to do is he's actually going to talk to us about cranial ultrasound scoring systems in HIE and give us a little bit of a feel of AI systems in the diagnosis. So without further, I'm going to hand over to Dr. Jasim Shihab. Jasim, go for it.
Thanks, Alok, for the a lovely intro. I assume there are lots of participants
Yes,
for this, and they've already had a talk on HIE.
that's correct. So they've had a talk on HIE.
Yeah. So this talk is like kind of divided into 3 parts. What I'll do is I'll do a recap of images in HIE. And then I'll get on to the scoring systems. There are not too many scoring systems to talk about. Usually when Alok gives me a talk, it'll be on one of these topics which are not very often seen. So ultrasound scoring systems, not too many out there, but I have got what all is there covered in this talk, I guess. And then a few slides on AI in ultrasound, in neonatal cranial ultrasound. Again, very few papers out there, but lots of interesting things coming in the near future from the looks of it. So I'll start off. How many of you are aware of? Hello, can we make this interactive? Or do you want me to just go on?
We can have an interactive session.
All right. So how many of you are aware of cranial ultrasound scoring systems?
Not me.
Anybody using any scoring systems?
No, no idea.
All right. Okay, so what we'll do is in HIE, we'll do a recap of images in HIE. So I'll start off with the normal. So this is the normal head ultrasound, full-term neonate 1 day after birth. It's a coronal view. You can see the lateral ventricles. They appear somewhat small in the term baby. There is normal echogenicity of the brain parenchyma in the full-term neonate, and you can see gray and white matter echogenicities blended. So there is not too much of distinctive discrimination between the white and gray matter in a normal cranial ultrasound. So again, this is the normal sagittal view. You can, through the anterior frontal, it demonstrates the midline structures. You can see a normal corpus callosum, and the thalamus is seen here, the belly of the pons, and this is the vermis demonstrates normal echogenicity. So I assume you're all done with all this. Through the last few months, a few weeks of talks which have been going on.
That's
So
correct.
again, the parasagittal view through the anterior frontal demonstrating the corothalamic notch over here. Can you see my arrow, my pointer?
Yes.
Yeah. So, and this is the caudate nucleus over here and the thalamus over here. So just be aware of these images, because only if you know the normal, you can know what is abnormal. So the
Why are you
abnormal,
my laptop back? I want to take this in there.
Carry on, Jasim. Jasim, we've lost your audio.
can you hear me
Yeah.
now?
Yeah, you might just want to start with the abnormal again. Yeah.
Yeah. Sorry, it's raining heavily here, so there's a bit of erratic network. So the abnormal. So again, this is a coronal view through the anterior frontal. These images were obtained in a baby who had abruptio placenta and needed long resuscitation. Obtained at 2.5 hours of life. So you can see the bilateral symmetric increased echogenicity in the thalami, extending into the cerebral peduncles. Ventricles are slit-like due to edema from the central structure. So same baby parasagittal cut showing slit-like ventricle and increased echogenicity in the thalamus. Let me know if I'm going too fast. So this same baby had a follow-up head ultrasound at 48 hours, and you can see much more increased echogenicity and seen in both the thalamus and the putamen region. Same baby in coronal cut at 48 hours. You can see the entire basal ganglia and thalami again, both bilaterally, is a highly echogenic, suggestive of HIE. So sagittal cut again, where you see the echogenicity worsening throughout the corothalamic region. So this is another baby with near total gray and white matter injury. Again, it's a full-term neonate. Head ultrasound was performed at around 17 hours after birth. You can see the edema is represented by the high signal throughout the white matter. What you see here in the cingulate gyrus. Note your slit-like ventricles here. And you can see high echogenicity, the thalami as well. Again, the parasagittal view shows echogenic thalami. And there is near total white and gray matter injury in this full-term neonate. There is cerebral edema, which you can see from the swollen appearance of the brain slit-like ventricles, almost impossible to visualize these ventricles. And there is marked differentiation between gray and white matter. So again, it shows increased echogenicity with basal ganglia and thalami with poor distinction of the borders of the basal ganglia and the thalami as well. This is another image which shows slit-like ventricles with edematous features of HIE. So one of the other things which can happen is brain swelling, and there is increased gray white matter differentiation. So what you see over here, subcortical white matter, hyperechogenic white matter, you can see in babies with HIE. A few more images. You can see the basal ganglia. This is a zoomed in image where you see a hyperechogenic basal ganglia. This is a moderate HI baby. So there are some babies known to have IVH at term as well because of HIE. You can see the sagittal sonogram showing intraventricular hemorrhage over here.
It's already in the lecture. I'm just trying to open what you need to share.
Yeah.
The first
Shall,
teaching.
shall I go on?
Yes, sir.
I will go on.
Not already.
So one of the other things you look for in a baby with HI are the Dopplers, where you do Dopplers. Sorry, shall I hold?
So you're just echoing a bit, Jasim. Just let me have a play with the system.
Yeah. Am I going too fast?
No, it's
So you're
okay.
fine.
Can the order for morphine and metas for NDCM? I don't know how to. I actually
Somebody-
informed the
I'm having a
doctor
call as
one
well.
day.
So apologies if I get a phone call and I have to go for a
He
couple
left
of minutes.
He left. Next who will come on? Tanvir. Tanvir also.
Look.
Jasim, go for it now. You should be okay.
Yeah. So resistive index, put out a question there. Do you need to do it at all? I can't see it.
Yes, we need to do to ensure the perfusion and whether hypoxic injury is worsening or not in the serial ultrasounds.
Yeah, it was a very good marker. Less than 0.06 was a poor outcome predictor in non-cooled infants. But it has become less reliable with once the babies are being cooled. What they say is that because in post-cooling there is hyperemia, which occurs there as well. So your resistive indices are not very reliable once the babies are cooled. So it has been shown in scoring systems and validation studies as well that it doesn't correlate well with the outcomes as previously seen in studies done when babies were not cooled or not undergoing hypothermia, therapeutic hypothermia. So basically, you put a Doppler across the anterior cerebral artery, and you get a Doppler over here. This is a good resistive index where you have 0.7, and it is a relatively common thing we all used to do once upon a time, but nowadays within the first 24 hours, people don't do it much, and in cool babies, it is not very reliable. So that was a kind of a recap of HIE images. Before I thought I'll show all those images so you kind of get the idea of how you go about scoring them. So from the next few slides, we'll talk about scores, the papers which are out there regarding cranial ultrasound scores. And how one of the most recent papers has done a validated scoring system which can be used clinically. So this is a very recent study. It was done to show the utility of cranial ultrasound, whether it actually helps in the era of MRI to investigate brain injury in hypoxic ischemic encephalopathy. So there were a total of 94 infants which were included in this study. Ultrasound was performed in the first 5 days after birth, and brain MRI was done around 6.7 days. So what they found was that both the white matter injury on cranial ultrasound less than 24 hours and gray matter injury after 48 hours, they had good correlation with the severity of brain injury on brain MRI. So essentially what they're saying is that if you don't have an MRI, if you can do good cranial ultrasounds, you can still predict neurodevelopmental outcome with those. So that was the big question which people used to ask, because MRI is definitely out there, and you get much more clarity with the images. But this paper, which has come out February 2025, has shown a good correlation with cranial ultrasound and brain MRI. So they did a subgroup analysis of the ultrasounds performed less than 24 and 48 hours, and they did MRI on days 3 to 5, and there was good correlation between brain injury between both the modalities. So that like kind of leads us to the question: should we do scoring? Should we do ultrasound at all in these babies, or go ahead with MRIs only? So this paper proves that ultrasound is as useful as an MRI. Do you all do day one ultrasounds in babies who have who undergo therapeutic hypothermia or who have severe HIE, moderate to severe HIE? Do you actually do ultrasounds before you put the baby on cooling?
No.
Not before cooling, but possibly, if possible, on day one, we would like to do.
Okay. Right. I'll get to my answer to that in the next few slides. So this is another paper which it's slightly an older study, which is there are only very few scoring studies out there. Most of them are not validated. The next one I'm going to show is actually validated. So this paper it showed imaging patterns of brain injury in term birth asphyxia. So the aim was to develop an extended asphyxia score based on ultrasound and MRI. So it was combined with ultrasound and MRI in order to gain further insight into the pathophysiology. So first week cerebral ultrasound and MRI of 80 asphyxiated term infants were done, and they identified 6 patterns of brain injury: deep gray matter injury with either limited or extensive cortical involvement, damage to deep gray matter with watershed injury, isolated watershed injury, isolated white matter injury, and isolated cortical necrosis. And they found that there was extensive mortality in babies with extensive cortical injury, which is well known. So this is the only actually validated scoring system out there. This paper, which they did, came out in 2022, and all the big names are there. I'm sure most of you would have heard of Linda DeVries and Charles Rohr, people I know personally. And all the big names in the neonatal neurology field have participated in this trial or in this study. So what they did was they took neonatal infants with HIE who had undergone therapeutic hypothermia, and also the babies, they ensured that these babies had cranial ultrasounds done on day 1 and day 3, and between day 3 and day 7 after birth. Also, they ensured that the babies had available outcome data. So this was a retrospective cohort of babies, 2014 to 2020, I guess. And they looked at all the babies who had therapeutic hypothermia, who had cranial ultrasounds on day 1 and day 3, between day 3 and day 7, and also had 2 years Bailey's developmental follow-up. Then they put the findings on day 1 and day 3 and 7 were related to adverse outcome. They found that in univariate and day 3 to day 7, also in multivariate logistic regression analysis. So then what they did was they did a scoring system. Once they got the scoring system through, they used it in another hospital. They took another 40, 50 cases. Similar story, HIE, hypothermia, brain ultrasound day 1 and day 3 and day 7. And they put their scoring system to test there. And they found that it validates very well. So what was the scoring system they used? They looked at both white matter, gray matter, and something called a 4-column sign, and also the plick in an ultrasound, which is something relatively difficult to see, but it is there. You can look at the posterior limb of internal capsule in the ultrasound. So what they graded it to mildly abnormal, moderately abnormal, and severely abnormal. So impaired white-gray matter differentiation or slit-like ventricles. If there was normal differentiation between gray and white matter and open ventricles, it was scored 0. Moderately abnormal was reduced differentiation and slit-like ventricles. Severely abnormal was there was no differentiation at all between gray and white matter and slit-like ventricles. They looked at the hyperechogenicity of the periventricular white matter. I'll come to the images. I've got all the images in the coming slides, but I'm just giving you the background. They looked at the periventricular white matter. If it was normal echogenicity or minor hyperechogenicity, they gave it normal to mildly abnormal score. If there was moderate or focal, then they gave it moderately abnormal. And if it was severe or diffuse hyperechogenicity as white as the choroid plexus, it was severely abnormal. Then they looked at the hypoechogenicity, subcortical white matter. Again, similar, normal, focal, and if there were clear tram-like signs of the subcortical white matter, then hypocyclic intensity of the cortex as well in between. They gave it moderately abnormal, severely abnormal with a score of 2. Then there was the thalamus and the putamen, normal, moderate, focal, and severe hypoechogenicity. So these were the things I was showing you in the previous images so that you're aware of what is normal, abnormal, and then we can go into the scoring system based on what they found. There was also something called a 4-column sign. Has any of you heard of a 4-column sign? Which they looked at. So whether that is normal echogenicity or hyperechogenicity. So what is a 4-column sign? On the ultrasound plane, there is a 4-column sign caused by moderate or severe bilateral hyperechogenicity of the thalamus and putamen. Basically, the thalamus and the putamen bilaterally will look like 4 columns on your ultrasound. I'll show you the image next. And then they looked at the plick as well. If the plick is generally not visible, if it is clearly visible, they gave it 1 point each. So white matter involvement was sum of edema, periventricular and subcortical white matter damages, which is around 6 points. And the gray matter involvement, they used hyperechogenicity of the thalami putamen, which is all the gray matter in the brain, and the visibility of the plick and the 4-column sign. So this is how the graded is. So moderate cerebral edema. Here you see slit-like ventricles and increased echogenicity differentiation. They give 1 point. And this is even more severe. You almost can't see the ventricles and you see severely increased echogenicity. Can you make this out?
Yes.
Yes,
Yeah.
yes.
Yeah. So they gave this 2 points. You can see the difference here. This is moderate. You remember the normal I've already shown you, and this is the severe cerebral edema. So this they gave 2 points. Then they looked at the periventricular white matter. Again, if there is increased echogenicity there, moderate, they gave 1 point. This is severe. They gave 2 points. Then they looked at the subcortical white matter, which they gave 1 point. You can see it over here. It is much more severe in echogenicity. They gave 2 points. Then they looked at the thalamus. So this is a moderate increase in echogenicity. And this is a severe increase in echogenicity. Then they looked at the putamen. So the putamen, again, this is a moderate increase. and this is a severe increase. So what is 4-column sign? You see the thalamus, the putamen as 4 columns. 1, 2, 3, 4. Can you see what I'm showing?
Can you repeat, please?
So you see the thalamus bilaterally and the putamen bilaterally. All right. You see that as 4 columns here. 1, 2, 3, 4. This is what they call as a 4-column sign, which means both the left and the right thalamus and putamen are visible at the coronal view as 4 columns. Got it? So if the babies had this, they gave another extra point for that. And then the visibility of the plic. You don't see this hypoechoic region generally. If you see this, that is the posterior limb of the internal capsule, which you're seeing over here, just next to the thalamus. Can you see that? I'm sure all of you have seen a plic in an MRI. Yeah, you saw my arrow, isn't it?
Yes. Yes.
Yes.
So if the plic is seen, they give it 1 point. So using this code, they had 2 radiologists and neonatologists looking at all the images of all these babies for both the day 1 and the day 3 to 7 ultrasound scans, and they then scored these scans using these scores, and they did that for day 1 and the day 3 to day 7 as well. What they found was that the day 1 scans were not predictive of outcome. They also looked at the outcome data for all these babies which they scored. And they used Bailey's 3 to look at the outcomes. And they also looked at the GMFS scoring as well. And what they found was that the day 1 scans, when they looked at only day 1 scans, it was not predictive of outcome in the study. It takes 24 to 72 hours before brain injury becomes visible as hyperechogenicity, unless the onset of the process is of antenatal onset. Cranial ultrasound within 6 hours after birth had, in a previous study, a low sensitivity as well, 40 to 1%, and specificity of 60% only. But you still have to do a cranial ultrasound on day 1 to identify antenatally acquired other pathology, to see if there's anything else abnormal with the brain. So it is good practice to do your ultrasound on day 1. So they included 83 infants in cohort 1. The final ultrasound scoring system contained the sum of white matter, good odds ratio, and deep gray matter involvement as well. Both the area under the curve was 0.9 and 0.89, almost equal for both cohort 1 and cohort 2. So the cohort 2 is what they did is the cohort 1 is from one hospital in Netherlands, and the cohort 2 is from another hospital. So they used the scoring system this cohort 1, they used to derive the scoring system, and then tried that scoring system on this cohort 1. And then the same scoring system which they derived, they put that on the cohort 2, with which they found that it is validated. The scoring system works in different settings. So this is the only validated scoring system currently available if you're looking at ultrasounds. Now, why do we need this is the big question. So the MRI in LMICs or low and middle income countries is not always feasible. Sometimes the babies are too sick to be transported. So if you have good cranial ultrasound machines, and if you are a good operator, which we are, Alok, and we are all trying to make you become, then you can use these scoring systems to actually make predictions for the future development of the child. So any questions on this? So that was the bit about the scoring systems in HIE. Before I move on to my
How does this scoring system guide us with providing the prognosis for the future development? Means how do we interpret it? If it
So
is
if
mildly abnormal or
so if it is
moderately abnormal?
if it is moderately the moderately abnormal ones, there are high chances of dyskinetic CP and future cerebral palsy, which can occur with your sorry, there's a question there. Yeah, which can occur with the thing. So your general scoring system, both white matter and gray matter scoring systems, they do. You have a 0 to 6 points you can put based on what I showed you. I can send the article across as well. And based on that, the higher the score you have, the worse the chances of prognosis. That's how they mentioned. So your if you are severely abnormal, if your score is around say 8 to 12 points, then your chances of neurodevelopmental delay are very high. So this was actually a retrospective cohort of studies. Now they are actually working on putting the scoring into prospective studies.
Okay.
Did I answer your question?
Uh,
What is PLIC?
Thank you
PLIC
very
is
much.
the posterior limb of the internal capsule. Somebody asked, what is PLIC? That's the short form for posterior limb of internal capsule. Yeah, somebody has already answered to that. So that's something which we look at. The echogenicity of the posterior limb of internal capsule is something which we look at in MRIs. When we look at MRI, HIE MRIs, it's very rarely looked at in cranial ultrasound. I'll confess that it is only when I started looking at these scoring systems that I actually saw that PLIC is useful in ultrasound as well. I then went and did a few ultrasounds to see if I can see a PLIC anywhere as well. So I could not see it on any of the babies. I did it because they were all term normal babies. It's just to see if actually what they showed in the scoring system was right or not. Any other questions on this topic before I move on?
Yes, good day, good evening.
Good
Thanks
evening.
for the presentation. I just want to know that if I need to do this cranial ultrasound just once for babies with HIE, when do you think be appropriate to do it?
So ideally it should be between around 72 hours. Would be a good time to do
70.
it. Yeah, if you're planning for prognostication, but
Yeah,
it is always good practice to do one before you start cooling these babies, just to see that you're not dealing with something else. You don't have any other cranial abnormalities there.
okay.
Yeah.
Thank you.
Welcome. Shall I move on? I only have a few slides on artificial intelligence. There's not too much out there. So artificial intelligence, has anybody used artificial intelligence in ultrasound or for that matter in neonatology?
Not yet.
Not yet.
Chat
Yeah.
GPT sometimes.
Yeah. ChatGPT and Gemini and all these systems out there, they are all part of the artificial intelligence which is coming out. So what exactly is this artificial intelligence? So basically, it's like creating intelligent machines which are trying to mimic human intelligence. So you would have heard a lot of terms like machine learning, neural nets, CNNs, AGNNs, deep learning. So these are all subsets of artificial intelligence. Basically, what you're doing is for machine learning, you are creating algorithms enabling computers to learn from data. So you basically throw in a lot of data and then the machine and you give algorithms to it. So the machine learns from that data, and then the more data you add, it keeps learning and it comes out with an output. Then you have the neural nets. So that these are computational models which try to behave like the brain neurons. So they are all interconnected artificial neurons. So in that you have the CNNs and the AGNNs, which basically is also deep learning is also a part of that. Are all basically neural networks. What you throw in an input, and then this goes into multiple deep complex learning pathways and learning layers, and it gives out an output. So for instance, you throw in a bad image of an ultrasound I did. The deep learning machine will go through 1 million ultrasound images and then get a good image and bring it out and throw it out there and give it to us. So deep learning techniques are the ones they use for various applications. So what are the applications in neonatology? So you have both machine learning and deep learning applications. So the machine learning is used for image data, so for photos, CT, the retinal images, your MRIs, all that. It also is being used in vital signs monitoring, for instance, heart rate, blood pressure, and saturations as well. All the signal data, they use machine learning. So basically, if you see all these automated reporting of ECGs, EMGs, EEGs, all that is because of machine learning. The machine actually learns from all the data which is fed into that, and it actually tells you that this baby is having seizure, this baby is not having seizure, this is a status epilepticus, this is not a status epilepticus. The technology has come for that. It's already out there. Then you have the voice data. So from infant cry, it actually tells you the NICU noise is loud. You have to bring down the decibel rate in the NICU, or the incubator noise is loud. So the based on whether the infant is sleeping or not, the incubator will be able in the future to adjust its alarms. So that's the voice data which is going in, and then EHR. So you'll have all the audits you're doing, all the data you're collecting and analyzing. All of that will be automated because of machine learning in the future. You'll have the Bailey score. All you have to do is put in your input, and then you'll have exact predictions from the Bailey score as well. And then you have genomics and exome, where multiple use cases are being used. In deep learning, again, images. So deep learning is more to do with image rectification, image clarity. It actually it is out there actually. Neonatology is poorly funded, unfortunately. But if you go into the obstetric world, you are having new ultrasound softwares which are coming out, which are using deep learning and AI. So when you're doing the scan, it actually tells you whether you have captured the best image. It actually tells you what image you have captured. You don't need to do your measurements anymore. It automatically will do your measurements and then put it out there. Fundus images, you have the red cams now are getting infused with AI now. So people are actually using mobile phones to get fundus and retinal images, and the AI actually tells them whether there's a problem or not now. So again, ECG, EEG, vital parameters are also being looked into with deep learning, and EHR is also being looked into. So these are the different applications where in neonatology things are being tried. Some of them are being, some papers are out there, some research is going on. I'll give you an example of a research in the coming. So use cases in neonatal cranial ultrasound, I've already said a few, but basically you'll have automated measurements which will be coming in very soon. For instance, when you're doing a cranial ultrasound, you don't have to do your ventricular indices. The machine will automatically do it. It will actually pick your right image, the best image you've got. It will filter the image, make it much better as well, and then do your scoring, the ventricular indices measurements, and it will tell you that this is what your ventricular indices are. So that is automated measurements. It is already out there in other ultrasound, other areas of ultrasound now. So the other use case is abnormality detection. So all you have to do is put the probe there. It will tell you and once you get the right image, it will tell you that You have this, say the baby has Dandy Walker syndrome, the baby has whatever molybdenum cofactor deficiency, without us knowing too much about the actual stuff. Image processing. So it'll actually make if you're not good at doing your scans, but if you know how to put your probe in the right place, it'll actually process the image and make it good, and then tell you what is wrong with the child as well. So that those research is going on as well now, and all this is maybe things are actually being completed as we speak. It's that fast. And workflow optimization. So because of all the data there, it's actually optimizing your workflow. You don't have to waste too much time. All you have to do is one sweep, and all the images will be caught because of AI, and then will be fed into the system. You don't have to store it, freeze it, do anything. All you have to do is just do one sweep with the probe, and you get your image. So what generally takes around 20 minutes will take 2 minutes. That's what the future will be. So it reduces operator errors, improves accuracy. There is faster turnover by improving efficiency. And once they find an abnormality, the machine in the future will automatically create a personalized treatment plan for whatever the abnormality is. So that is the future. So this is one of the papers which came out very recently in December 24, where they used deep learning model for predicting neurodevelopmental outcome in very preterm infants. This was done in Nova Scotia in Canada. So they took a retrospective study of a cohort of very preterm infants, 22 to 30 plus 6 weeks gestation, born between 2004 and 16. They looked at the clinical data at hospital discharge, and ultrasound images at 3 time points were used. So at birth, the first ultrasound image, at 6 weeks, and at term. At these 3 time points, the ultrasound images were used. And then they put it into the CNN network, the elastic net and the convolutional neural network. Basically, these are deep learning networks. Then they looked at the model's performances using the precision recall area under the curve and the area under the receiver, the AUC as well, with 95% index CIs. So in the model 1, they tried 3 models. So the model 1, they used CNN or the convolutional neural network. In there, they used only ultrasound images. They got a PRAUC of 0.73 and ROC of 0.68. It's not bad. They used clinical variables and cranial ultrasound, and they got a 0.75 and a 0.71. When they used only clinical variables, they only got 0.6. So they actually validated and deep learning prognostic model was validated using the ultrasound system and clinical predictors to predict NDI. So what the conclusions were that early and accurate identification of infants at risk for neurodevelopmental delay enables referral to targeted interventions, which improves functional outcomes. Now, why they did it at 3 years is most of us do our scoring at 2 years, isn't it? Neurodevelopmental index. So there are papers out there that babies who had problems found at 2 years with respect to developmental delay are doing very well at 10 years of age. Very recent papers come out. So the plasticity of the brain is unpredictable. So that is why they thought that not at 2 years, but they will do it at 3 years of age. So that's yeah. So that's one of the papers which I found. There are not very many papers for neonatal cranial ultrasound. Alok, stop giving me such difficult topics. Thank you.
No problem. So, folks, the most important take-home message from today's talk is basically the importance of recognition of HIE. But what is coming up in a big way is there's a lot of work that's being done on scoring systems and prognostication. And whilst the specificity of the cranial ultrasound scoring systems are on the lower side, the sensitivities are pretty high in terms of positive correlation between a high score and a diagnosis of cerebral palsy later on. Now, for those of you who are interested, when you get more, I would say, au fait or comfortable with actually being able to recognize HIE, the ability to use scoring systems for prognostication can be quite important in settings where you might not have MRI, say, for example, because an MRI might not be available or might be extremely expensive, and you have to provide, prognosis not just on the clinical course, the clinical history, the clinical presentation, but also based on the neuroimaging findings. So I think this is probably an additional tool in your arsenal that you can use. And it would be very interesting, as we go forwards, to kind of see whether those of you who work in particular in countries where there's a high incidence of HIE, but there's a lack of neuroimaging facilities, whether you're able to validate such scoring systems. Again, a little bit of caution. I would not use cranial ultrasound on its own without the resuscitation, clinical course, clinical history, examination. I would use it as an adjunct, and that is very, very important. I think if you start just using imaging itself to try and prognosticate, that is laced with risk. Any questions for Dr. Shihab?
Yes, please.
Go for it, Alberto.
Okay. How do I know if the plaque is really hypoechogenic or only looks hypoechogenic because the basal ganglia and thalamus are hyperechoic?
So you won't be able to see the plic at all. It'll be really hypoechoic if it is seen. So you, in actuality, in a baby who is not having HIE, severe HIE, moderate to severe HIE, you won't be able to see that much of hypoechoic area there. So if you're actually seeing a hypoechoic area in between the thalamus and the putamen, that means that you are seeing a plic, and yeah. So that's how you know. Otherwise you won't be able to see that hypoechoic region at all.
Okay, thank you.
Yeah, what Jasim would also kind of imply is that actually it's the brightness of the other regions and the relative contrast between the two that might make the plic apparent. And doing serial scans in those circumstances may be really, really helpful.
Thank you, Dr. Alok.
Yeah. Any other questions?
Yes, thank you very much. I practice in Nigeria, and 40 to 45% of my patients comes in with HIE.
Can't hear you. Sorry.
Hello?
Yeah, your voice is very
Yes.
low. I think you need to increase your volume.
Okay. Okay. I said I actually work in Nigeria, where majority of my patients.
Hello, can you hear? I can't
Yeah,
hear.
I can hear. I can hear. I'll translate. Go for it. Yeah, carry on, Tolalupe.
Yeah. Okay.
Oh,
So
now I
I
can hear.
actually joined this group. I actually registered for this course because I was about to start a work on HIE and cranial ultrasound. So I just want to ask that there's some aspect of this training, of this teaching, or this talk that I didn't really understand very well. The scoring system and differentiating thalamus and basal ganglia, the echogenicity is still a bit a problem to me. So I don't really know what to do. On the FD testing on cranial ultrasound and HIE.
So, Tolalupe, one of the things that's quite important in those circumstances is actually making sure that the clinical correlation between your diagnosis of HIE, because you'll have both inborn and outborn babies. And in those circumstances, it's quite challenging then to kind of understand whether this is HIE or whether there's sepsis in the background as well, or whether you have an alternative diagnosis. But if you're finding that, you've got a frank diagnosis of HIE and your imaging is really showing no brightness, one of the things that you might want to look at is the gain settings. So very happy if you have any cases and that you want to share, even if you want to have a one-on-one session for us to look at it and look at your machine to see how we might be able to optimize that.
Okay.
Yeah, I think I understood the question, but from what Alok said, you also have most machines now have auto gain settings. So if you don't think your image settings are right, you can there's an auto gain button there, which you can press, and that kind of helps with the gain as well.
My only
Okay.
other comment is that sometimes what you might want to do is you may be using the settings, but you might have to magnify the images a little bit. And magnification
Okay.
comes by increasing depth and focusing on those regions. But
Okay.
really, with severe HIE on the first day, those findings of cerebral edema, slit-like ventricles, and what I would say is a very bright echogenic kind of a cerebral appearance, where you can really differentiate areas from other areas, is a giveaway. But
Okay.
the good way to learn is for babies who heal. Often you'll see improvement. And if you're able to do serial scans, day 1, day 2, day 3, and capture those scans and then compare them, you'll really be able to get a better interpretation of the diagnosis of HIE. And I mean, over the next few weeks, what we'll be doing is really, now that we've covered virtually every topic other than screening, is we'll be going through cases with
Okay.
histories that I'll be giving you with the scan findings without telling you what the results actually are, so that you can actually make the diagnosis yourself. And that'll include cases of mild, moderate, and severe HIE alongside other pathologies. Just we must also remember that in countries like India and Nigeria, often HIE might be the effect of not just hypoxia, ischemia, in utero, but actually children with sepsis or children who may have been resuscitated, say at home, may have postnatal hypoxia, ischemia, and some of those findings may actually overlap. So, it's quite interesting in those circumstances then to see and follow those babies up serially to see how they progress. So
Okay.
I would strongly encourage that, for the next, like what our plan would be, the reason for some of these sessions being held on the Sundays has been so that people
Okay.
who can't attend on the Thursdays, we've had a few people who can't attend on Thursdays be able to
Yeah.
attend the didactic sessions. But now what we will be doing is organizing alternate Thursdays and Sundays where we'll be giving you cases, and very, very interesting cases for you to basically be able to diagnose. The intention is now that we go into the clinical contextualization of all the theory that we've kind of gone through. So I'm sure that'll help, Tolarupe.
Okay. Thank you very much.
Any other questions? I would like to take this opportunity to thank Dr. Jasim. I'll be sharing the articles with you on cranial ultrasound scoring. And there's also another scoring system for hydrocephalus that I'll be sharing with you. So we'll be sharing a few topics. The next session is planned for this Tuesday evening. Don't worry for those of you who can't attend, it's on screening. But really, from our perspective, one of the fields that I want to get from you in the WhatsApp group is whether sessions better done on alternate Thursdays or Sundays, just to get a feel of what works for everybody. And the intention from my perspective is to kind of give you a lot of cases that you probably might not have seen before, that you'll be able to diagnose yourself based on the history. I've got Alberto saying best on Sundays. That's great. But if Thursdays are also good for a group of you, it means, some of you can attend on the Thursdays. So we're going to mix sessions up a little bit. So I'd like to thank you all for your time, and God bless you all. Have a good evening.
Thank you.
Thank you all.
Thank you.
Bye.
Thank you,
you.
Jasim. Thank you so much for your time and
Thank you so
presentation.
much.
Thank you
both.
so
Thank
much.
you. Thank you. Bye. Thank you.